Good morning, everyone. Welcome to the Medicaid Transformation Waiver update. My name is Kaylee Morris with the Healthcare Authority. We're just going to go through a couple logistics slides first, and then we'll get the presentation underway. So first, if you have any questions throughout the presentation, please type those into the question pane. We will save the question and answers for the end of the presentation. This is also an opportunity to do a sound check. If you can't hear me, then when we can finally get the slides to work, there's directions there. Although if you can't hear me, you're not hearing that piece. So today's presenters. So again, I'm Kaylee Morris. I'll be facilitating. I'm a project manager at the Healthcare Authority. We're joined by Nathan Johnson, the Chief Policy Officer at HCA, Marianne Lindeblad, the Medicaid Director, Mark Province, Medicaid Transformation Manager, B. Rector, the Director of the Division of Home and Community Service at DSHS, and John Brumbach, Senior Health Policy Analyst here at HCA. So topics for today, we'll start with an update on this past legislative session as well as an update on our conversations with CMS. We will go into value-based payment and how the movement towards value-based payment is critical to this waiver demonstration success. We'll talk about Initiative 1, the recently released transformation framework that many of you helped contribute to during the project idea process. Provide an update on waiver initiatives 2 and 3. And we'll also talk about next steps, and then again save time for questions and answers. So please write your questions in as they come up. So we'll be jotting those down and theming them to make sure we can answer as many questions as possible. And then where to find more information. Our website is always going to be the best place to get the most updated information. We try to keep all resources on there. As I mentioned, the recently released project framework is there now. We'll have an updated FAQ this week as well. We'll also be posting a survey with some questions to the project framework, as well as all previous webinar presentations. We'll have the slides for this webinar up by tomorrow. And then as well, this is where we'll be posting updates on workgroup activities and other CMS updates as they come up. And as always, send questions and comments to medicaidtransformation@hca.wa.gov. And with that, I'm now going to transition this to Nathan Johnson.
Thanks, Kaylee, for that introduction. And it's my job to get through the next couple slides in as quick a time as possible, but also give you a meaningful update on where we've been since the last webinar we all gathered together on. So starting right at the top here with the legislative session and the budget authorization for the waiver. As folks may or may not know at this stage, the budget that passed the legislature and was signed into law by the governor provided explicit federal financing authorization associated with the waiver's 3 initiatives. Initiative 1, 2, and 3 each have their own federal appropriation attached to them, and we are very pleased to see that those provisions in the budget that pave the way and give legislative authorization for implementing the waiver, because that is something we believe we'll need between now and the next legislative session. So I wanted to start there. As an update on the CMS side of the discussions, the first thing I'll say is everyone, all parties to this discussion are very motivated to get to yes. There is genuine belief in the programmatic and policy direction of our Medicaid transformation proposal at the CMS level and with their federal partners, and now it's a matter of getting to yes, which I think is a very good position to be in at this stage. The budget discussion is where it is focused now. Again, there has been a high-level endorsement of our programmatic approach by CMS. Tied to the budget discussion is the continued need to identify sources of non-federal share. We've made significant progress on describing designated state health programs to CMS that would qualify for federal match. As well, since the last time we spoke on a webinar, we have been asked to pursue intergovernmental transfers, which although had not been our original original plan heading into this discussion, we had intended to focus primarily on dish fees. CMS has asked, and we have agreed to pursue the use of intergovernmental transfers primarily through public hospital entities that would be participating in providing the non-federal share. There have been good discussions with hospital partners to date of a more informal nature, and we expect those to heat up over the next several days and weeks. Moving on to the context for this Medicaid transformation discussion, and while I will be brief here, I think it is always important to stipulate what the actual goals of this effort are before we get into some of the details. First on the list is reducing avoidable use of intensive services and settings. I think we can all agree that there is significant potential, whether we're looking at acute care hospitals, nursing facilities, psychiatric hospitals, long-term services and supports, and jail settings. We want folks getting their care in as upstream manner as possible to avoid the much more costly use of intensive services and settings downstream. Second of our 4 goals here is to improve population health, focusing on prevention and addressing management of significant disease patterns within our Medicaid population, and you see several of them mentioned there. The third, and we'll be discussing more on this in a moment, we want to accelerate the transition to value-based payment. We want to leverage payment methods with our Medicaid population that take the quality of services and other measures of value into account. And finally, we want to ensure to our own authorizing environment as well as to our federal partners that our Medicaid per capita cost growth remains below national trends. And we have proposed ways of measuring that and achieving that under the transformation waiver application. As I briefly alluded to earlier, and as those who've been following this discussion will now understand, we have 3 initiatives associated with this waiver. It is not my job here to describe those in depth because we will be giving you a fuller update from a variety of perspectives on where we stand on these 3 initiatives. But just to outline them for you broadly stated. The first initiative deals with delivery system reform and helps finance transformation projects across the state led by accountable communities of health that will be able to pursue projects that will transform the Medicaid delivery system and serve the whole person using resources more wisely. To this point, and a point of further discussion in today's webinar, we have released the outline of a project framework, an early document that suggests what a project toolkit will ultimately look like downstream in this waiver discussion. Initiative 2 is focused on enabling older adults to stay at home and delaying or avoiding the need entirely for more intensive care. There are 2 benefit approaches, Medicaid alternative care and tailored supports for older adults. You see fuller programmatic descriptions in front of you, so I'll skip those for now. Initiative 3 targets foundational community supports with 2 benefits, in particular supportive housing and supported employment. We will speak a bit more detail about how we see these benefits being delivered administratively and how we would onboard them through the 5-year waiver process. Washington's transformation initiatives under Initiative 1, important to stress here, it is a unique approach. In addition, Initiatives 2 and 3 are further unique approaches, and this is important because we are trying to demonstrate something to CMS. It would be very hard for us to make a case on a demonstration proposal if we weren't in fact demonstrating something very new and novel and something that we intend to evaluate very closely. Another important things to stress here for you, funds under Initiative 1 are strictly for delivery system reform incentive payments, which are pay-for-performance projects. Importantly, this is not a grant program, and I know you've heard us say that before, but I want to stress that today. In addition, at a high level, Initiatives 2 and 3 are service funds and will flow through service delivery systems that exist today. As has been stressed, our Medicaid transformation goals, as I think will become even more clear, underpinning all 3 initiatives, but in particular, I would say with regard to Initiative 1 and its sustainability, value-based payment is an essential component. It is critical to the success and sustainability of our Medicaid transformation efforts, both during the 5-year demonstration itself and the years following. We have a Healthier Washington goal of creating 80% of all state-financed payments that includes in the Medicaid and Public Employee Benefits Program, ensuring that 80% of those payments are on the value-based continuum by 2020. The Medicaid transformation waiver will be leveraged to incentivize further movement towards these goals. Underpinning all of this is a belief that we cannot transform the way we deliver services without changing the input side and the incentives on the financial side. What you see in front of you today is a depiction of our approach to value-based payment under the waiver at a high level. And what I want to assure you today, again with limited time and reserving plenty of room for questions, we don't intend to go through this visual with you in much detail, but are intending to release follow-up documents that provide a greater level of detail behind this slide in coming weeks. But what I do want to kind of establish, at least as part of the webinar today, is at a high level how we're thinking about value-based payment. First, on the left-hand side of the column, you'll see managed care health systems, which remain the risk entities for behavioral health and physical health services in the Medicaid program. Their role is to contract with providers for Medicaid state plan services. Their role is to accept guarantees of quality and further incentives around that quality. Their role is to have a shared focus on the Medicaid transformation efforts, as well as further incentives to attain value-based payment goals. Importantly, I'll stress these goals are central to the Medicaid transformation proposal as well as broader Healthier Washington activity, and you see the goals listed in the middle column there. On a statewide basis, over the 5 years of this demonstration, we are proposing to reach 80% of all Medicaid payments being value-based by 2019 and 90% of all payments related to the Medicaid program being value-based by 2021. There's some other specific components of this. Before I discuss the rest of the visual, I want to stress. First, a fundamental component of this is shared performance accountability for project outcomes and common metrics that define those outcomes between the relationships that exist between healthcare authority and plans, between the relationships that will exist under Initiative 1, between the healthcare authority and accountable communities of health, and furthermore, shared performance accountability that will exist between managed care health systems and accountable communities of health themselves. And ultimately, that shared accountability for performance will be an arrangement that in addition exists between the healthcare authority and CMS. Moving back to the left-hand side of the column with managed care health systems, we are proposing several additional steps to ensure we can reach our value-based payment goals under this waiver, which will include tying a percentage of the premium for provider incentives to quality, as well as a percentage of the premium, putting that at risk for the performance against quality metrics. So to be clear, there's two components of this, and again, more detail coming in future documents for you. We do intend that a percentage of a premium, as it is already the case, be tied to actual provider incentives and payments to providers for quality attainment at the managed care provider level. And we intend for contracts to reflect that. In addition, separately from that, we intend to have a percentage of a premium that we are paying to managed care plans at risk for performance in a similar fashion to what we already have contractually today, but expanding the performance criteria that we are using, which is quite narrow and limited today for purposes of that percentage of premium that's at risk. On the right-hand side of the column, you'll see accountable communities of health with an enhanced designation and role that we see them playing for Initiative 1. That role includes planning and decision-making authority on transformation projects, implementation and performance risk for those projects, and incentives for quality improvement and value-based payment targets that the ACH will be responsible for delivering. Importantly, accountable communities of health under the transformation effort are not responsible for state plan services and are not going at risk financially for state plan service delivery. So there are two sides of the continuum and they interact very closely together. And the waiver is a driver but not the sole driver of elements that we're representing here today. Going up a level, you'll also see that we would intend to have value-based payment incentives on both sides of the ledger. We intend to incentivize managed care plan attainment of those value-based payment goals through delivery system reform incentive payments under Initiative 1. We also intend for accountable communities of health and providers and other member organizations participating with within those ACHs to be incentivized for value-based payment attainment, again, against the same backdrop of those goals that are central to this approach. What we recognize in this approach to value-based payment is managed care systems and accountable communities of health are interacting with the same traditional Medicaid providers as well as additional non-traditional providers and community-based organizations. So that I want to underline how important it is that we have common signals and common metrics that we are using to evaluate both our attainment of value-based payment goals, but as well attainment of quality. And finally, underneath all of this, you'll see some critical components, some that exist today and some that are going to be new through the waiver, at least is what we're proposing. First, you'll see an existing component, and that is MCO state plan services funding. These are dollars that go to MCOs for the provision of Medicaid benefits. Those remain under the auspices of managed care health systems, as we have discussed previously, and remain the sole responsibility of managed care programs under this approach. We also envision an additional element through the waiver that would be quality and challenge pools for exceptional performance of managed care health systems against these goals and against the quality improvement metrics that we establish. The third element, the orange element on the bottom you see, is disrupt transformation funding. These are the dollars that will flow for Initiative 1 projects and dollars that ultimately accountable communities of health will be responsible for overseeing. What we are contemplating at this stage, however, is an approach to financial management that would allow ACHs to focus on the decision-making responsibilities associated with Initiative 1 oversight, while requiring some of the administrative management of dollar flow and such to be managed on a statewide basis. More to come on that. The fourth component of this approach is the community reinvestment pool. Here we are proposing, both for the duration of the waiver and beyond it, some ability through this value-based payment approach to incentivize reinvestment at the community level by incentivizing quality attainment, incentivizing value-based payment achievement of those goals. We intend to set a separate pool aside for additional investment at the community level. Again, we're providing a high-level overview today of some additional levers that will be brought to bear through Initiative 1 and our value-based payment scheme. But our intent is not to go into too much greater depth today except to answer some of your baseline questions that may exist as a result of this brief description.
This is Kaylee. Before we head into the next section, I just want to let people know we are aware of the IT troubles that we are having. The webinar has capped the attendance of this webinar at 101 people for some reason, so we know that many people are denied entrance. So if your colleagues are trying to log on or having issues, we are trying to work on it. We have IT trying to find a solution. So we apologize for that, and we'll do our best to provide a link to the webinar recording directly afterwards, and of course can always take questions through email. So again, apologize for the technical difficulties we're experiencing this morning. So that will continue on, and Mary Ann will lead us into the next section.
Thank you. So now we'll focus on updates on Initiative 1. So specifically, we will be reviewing the processes that we use and reviewing the transformation project ideas and how they inform the development of the transformation project framework. Next, we'll walk through the project description specified in the framework and provide an example of what a final project could look like under the toolkit. And we'll also be providing an update on the 1115 waiver's role in accelerating the move towards value-based payment. So, just to reiterate, our discussions with CMS continue, and will continue past our previous estimate for an April approval in order to finalize the budget-related issues. So if you look at this, remember back in December we went out soliciting project ideas, then used January through mid-March looking at reviewing. We've been working on developing the transformation framework, which was recently released, and then we'll be finalizing that. So with the release of the framework, as I mentioned, our key programmatic activities do remain on track. So we're moving right along. And once we reach an agreement in concept, we hope to move more quickly into negotiations of the standard terms and conditions with CMS with the development of those standard terms and conditions in terms of what will be held accountable to. And then the final toolkit will be released after those STCs are approved. So if we are able to remain on track, hopefully moving into some time late spring. So in terms of, excuse me, the transformation framework, just a reminder, and you've probably heard this, we got over 180 project ideas submitted, and we've used those to inform the projects outlined in the framework under all 3 of the domains. If you recall, the domains of health systems capacity building, care delivery redesign, prevention and health promotion. The framework for the Project Toolkit is an outline from which the final toolkit will be built. So with this framework, we'll be able to ultimately have use in terms of building out that final toolkit. And again, this framework, when you see it, if you haven't had a chance to look at it already, it reflects the project elements. And these were actually inspired by the ideas from our partners and our stakeholders, all that they've submitted, part of that 180 project ideas. And we have prioritized those for the toolkit, along with some project-specific objectives and some of the outcomes that we have envisioned. So with that, I want to transition to Mark Province, who will be talking in more detail about the Project Toolkit.
Thanks, Marianne. It's probably important to maybe just review a few terms just so that as we use them, there's enough understanding about what we mean. Remember that the original submissions that we worked from are project ideas, and that's how we've been referring to them, the 180 ideas that a number of people submitted from throughout the state. We'll be talking today specifically about a project framework, and that framework ultimately leads to a project toolkit. So hopefully we'll use those terms consistently, and you'll understand as we walk through this. So what we have just posted, and hopefully a number of you have had a chance to review this, is a project framework, and that really is the outline for the eventual project toolkit that we will submit and that will be ultimately approved by CMS. But the framework really does begin to work from those project ideas, group them under the domains that we reviewed with you before, and outline the ways in which we group them by rationale and also by objectives and outcomes. So if you look at the project framework document that we've posted, you'll see a number of elements that are listed here. There's the project summary, which includes the key strategies and activities. There's a rationale for the proposed project, and you'll see that represented in its own column on the project framework document. And it gives really the evidence basis and the reasoning behind what we're proposing in the project framework. We've also listed objectives and outcomes, which, again, deriving from what were the project ideas that were submitted, represent the project-specific goals and expected project outcomes. So this really becomes what we begin to identify as the outline, again, for the ultimate project toolkit. Subsequent to this document, we will develop core components, and these are key project elements that really will guide the implementation of the ultimate projects, and then finally the metrics that will be required. And these will be tied to the incentive payments that providers will earn as these projects are carried out, and have a little bit more to say on that in a moment. So looking at the design of the framework, one element that you'll see, which I won't spend more time on right now because Nathan did give a very good overview, and you'll see reflected in the project framework our attention to value-based payment is really a key theme throughout. But under Domain 1, which again, hopefully you'll recognize from our previous discussions, is health systems capacity building. The project idea submissions that we received identified several key capacity building strategies that in turn support the project goals. And we've captured these here. First is primary care models. We recognize that primary care teams are undergoing substantial changes in order to deliver whole person care. And this strategy focuses on supporting efforts for primary care practices that are undergoing this kind of transformation. It's important to remind you that as we've discussed in the past, the capacity building domain really is intended to build the support that enables the carrying out of projects that are in the other two domains. The second element that we've identified here is workforce and non-conventional service sites. And this really provides support for changes in the workforce, including training and education, needed to evolve into team-based, patient-centered care and ensure that the equity of care delivery across populations. Thirdly, our data collection and analytic capacity. And this really relates to the evolution of electronic health records, health information exchanges, and really those elements that work to improve the speed, quality, safety, and cost of the delivery of care. And this includes linkages to community-based care models, not just healthcare provider systems, if you will, but really the extension into the community. So these really are the three elements that we've captured, again, from the project ideas submitted that represent the elements under Domain 1. Domain 2 is care delivery redesign. As we've talked about before, and as you'll see represented in this first bullet of bidirectional integration of care, integrating mental health, substance use disorder, and primary care services has really been demonstrated to deliver positive outcomes and is really an effective approach for caring for people with multiple healthcare needs. The effective bidirectional models include systematic coordination of physical and behavioral health care and really represent efforts that are, some of which are already underway, but many of which were represented in the project ideas that were submitted to us. And I think everyone probably who's been paying attention to the development of our efforts here will recognize this has been a consistent theme throughout. Another element, again, that we derived from the project ideas submitted and really represented a key theme to us is care coordination. This strategy actually recognizes that individuals who are unwilling or maybe don't understand how to access and effectively use the healthcare system can't necessarily be expected to engage in services that are necessary to meet their healthcare needs. And many care coordination efforts face challenges in outreach and engagement that can negatively impact client retention. And so under this element, this recognizes that care coordination is in fact essential for the health management of defined populations, especially those living with chronic conditions. And it involves bringing together various providers and information systems to coordinate health services. It brings in foundational community supports and information to better achieve treatment goals. And thirdly, care transitions, again, is a key theme emerging from the project ideas submitted. And this really recognizes, and it goes back to some of the key goals that Nathan outlined, that transitions from intensive services and settings into the community are really critical intervention points. Many of those were reflected in what was submitted already, and this strategy identifies and addresses those system-specific gaps in care transitions. Finally, in Domain 3, we've changed the title a bit, perhaps from what you've seen before. This was called Population Health, and it's now reflecting the ideas that were submitted. It's titled Prevention and Health Promotion. The strategies under this domain really are divided into chronic disease prevention and management and maternal and child health. And we recognize and have recognized that a wide array of chronic health conditions is prevalent among Washington's Medicaid population, and the number of folks at risk for chronic conditions is increasing. And so this recognizes disease prevention and effective self-management really as critical to improving individuals' quality of life. In the maternal and child health domain, again, this recognizes that the Medicaid program really funds more than half the births in the state and provides coverage to more than half of Washington's children. And so, therefore, the project ideas that were submitted in this domain really came forward as important for us to retain under this domain of prevention and health promotion. It's also important to remind folks, and you'll see this reflected in the framework, that our focus in these areas also pays close attention to improving health equity. So how do we go from this domain to the actual project toolkit. And what we've outlined here is an example, and really this is only an example, so it's not to be taken as a final decision on what the toolkit will include, but it really is intended to kind of walk you through from the domain level to the ultimate elements of the project toolkit. So in this particular example, working from the care delivery redesign domain, this selects bidirectional integration of care really as one of those project areas. And then what you'll see reflected in the framework document are a number of objectives, and this really takes 3 of those objectives and represents them here. Addressing the needs of clients not easily engaged in primary care settings, improving clients' adherence to treatment regimens, and reducing avoidable intensive services and settings. So these 3 elements, domain, project description, and objectives, you'll see represented in the project document. What will come along behind this are core components and metrics. So an example here, following this theme, would be establishing behavioral health screenings in primary care settings as a core component of a project that would be represented in the toolkit, and also implementation of patient-centered behavioral health in primary care. And then finally, the metrics really are intended to be consistent with the work that we've done in our statewide common measures. And as a reminder, the metrics then become tied to incentive payments that are made to providers under the waiver. We've included here an example, and this is actually drawn from a report by MACPAC, which is the Medicaid and CHIP Payment and Access Commission in June of 2015. But this represents a very useful construct in thinking about the types of milestones that would be represented over the course of the waiver in looking at the development and evaluation of projects. And as you'll see, these really move from more process-oriented metrics, as we've talked about in the past, on the left-hand side, toward more outcome-oriented metrics as projects evolve and develop over the course of the waiver. So you can see these bullets as the examples of the kinds of measures, performance measures, that would be important to be represented as we put projects forward and begin to evaluate their progress. So I'll round out with just a slide on next steps. So we have the project framework out. There is a survey that will be made available to participants later today and will be actually available on the web tomorrow, I believe. And we've really gauged this survey as a way to gather your feedback in a structured way so that we can understand and work with the comments that you provide. So we've asked for folks to take a look at that survey and respond by the 27th. It's a short turnaround. Oh, actually, it's May 27th. It's a long turnaround. You've got a whole month. But we'd appreciate it if you can get your comments into us as quickly as possible. We will be including the framework in our negotiations with CMS. This becomes a very important element that leads to our special terms and conditions. As was mentioned, the state will develop, as a follow-on to the framework, the core components and project metrics as part of the toolkit. And then the draft project toolkit ultimately does need to be submitted to CMS for approval. So again, it's thinking along the continuum. We started with project ideas. You're now seeing the project framework. This will develop into the project toolkit, and that ultimately becomes something that is approved by CMS. So with that, I'd like to transition to B. Rector to talk a bit more about status and update on Initiative 2.
Kaylee and Mark, can you hear me?
Yep, I think you're on, B.
You're on, B.
Okay, great, wonderful. So just as a reminder, Initiative 2 creates 2 new service packages that would assist individuals with a need for long-term services and supports to receive services in their own home. Again, our goal is to try to delay or divert the need for more intensive services, particularly given the age wave in Washington State over the next 20 years. The first new service is the Medicaid Alternative Care Program. It's a new service for individuals who are eligible both functionally and financially for current long-term services and supports Medicaid. This is a new option and choice that would allow individuals who have an unpaid family member or friend providing their care. It would provide interventions such as respite, education and support groups, equipment and supplies that would help that caregiver continue to meet the needs of their loved one. And then the second benefit package is a new eligibility group called Tailored Services for Older Adults. This would offer a small package of services to individuals who are functionally eligible for long-term care but have income and resources that are too high to qualify for Medicaid. No medical service would be offered with this package, just the long-term services and supports package. So next slide, please. So much of our work right now is planning the types of systems and IT changes that are going to be necessary for us to implement these new eligibility packages and service options. Our goal is to be able to enroll clients into this service in January, pending approval of the waiver from CMS. And there are a lot of impacts from a systems perspective on our eligibility applications, ACEs and CARE, as well as our Get Care system and payment systems as well. So much of the planning is internal right now. We are just beginning planning efforts related to outreach and education. We are anticipating serving about 7,000 people over the 5-year waiver period at any given time, which really means that with the cycling through these services, we would be serving upwards of 20,000 people. So thinking about how do we quickly get information out to people, how do we enroll people within the first 3 years so that we have an evaluation period the last 2 years is really critical. So the development of brochures, fact sheets, education and information for the public, as well as individuals interested in participating in these services is critical. We do intend to engage our stakeholders in the development of those materials. And right now we're targeting probably mid-summer in terms of starting to get some drafts together for input. Next slide. State recovery is something that in our application to CMS we requested not apply to either MAC or to SOA beneficiaries. And we have received confirmation from the Centers for Medicare and Medicaid Services that a state recovery does not need to apply. We believe this is very important given the small benefit levels provided in these packages. And we've also heard from our stakeholders that it's going to be extremely important for the state to explain service options and choices to clients, particularly those eligible for Medicaid, so that they have a way of identifying which service package is going to best meet their need, and that the state also has ways of identifying when choices made by clients may or may not be meeting their health and safety needs, so that we can talk about making changes from the MAC benefit in particular into the more traditional long-term service and support systems. Next slide. We're also doing a lot of work on the application for both MAC and SOA. We want to make sure that people are easily able to access and apply for services. So we have been working with Washington Connections so that individuals can apply online and that that application contains information about these new benefits. We also are working on development of a paper application for the TSOA group, the Tailored Services for Older Adults. Again, that's a new eligibility group of individuals who currently are not eligible for Medicaid services. We also want folks to be able to contact their local area agencies on aging or their DSHS Home and Community Services office either by telephone or in person. So we're doing kind of an analysis of how people currently enter our system, how they learn about our service, and then trying to make sure that information about these new service packages are available, readily available in all of those options. Next slide. Eligibility is something that we want to make sure is, again, easy for clients. We know that individuals who receive unpaid family caregiver support or receive services currently under state-funded programs such as the Senior Citizen Services Act often do not access services every month. Oftentimes their need is sporadic or episodic, or they may have a one-time need for equipment. And we want to make sure that when that's the case, people have a continuous eligibility over 12 months, regardless of whether or not they receive a service each of those months. What that will do is prevent people from having to start an application process over again when they receive, let's say, a backbench in July, no service in August and September, and then come back in October, perhaps needing a service such as respite. So we've made a lot of progress in that regard and continue to work on how we can make sure that our ACEs, our eligibility IT system, can support that continuous eligibility. And then we also want to make sure, and CMS will want to make sure that the folks that we're providing services to continue to be eligible. So like all of our Medicaid services, we will need to be doing both a functional and a financial eligibility redetermination every 12 months. And then in terms of the last slide for Initiative 2, we have posted benefit specification descriptions on the website, and you'll see the link there on your slide. What this does is give you a better idea of the kinds of services and benefits that will be offered both under the Medicaid alternative care and the tailored services for older adults. We want to really thank folks who provided feedback on those specification sheets. They're now final. We also want to let people know that we are intending to use that website as a primary way of getting draft documents out for public review and comment. And so we expect that as we have brochures and educational information drafted this summer, that we will use the website as the place to post those to get comment. So I think the next speaker is going to be John on Initiative 3.
Thanks, Bea. So yeah, now we're going to provide a quick update on some of the development and work on targeted supportive housing and supported employment benefits under Initiative 3. So some of the key decisions that have been made since we last provided an update are some decisions around supportive housing phasing of the benefit, medical necessity criteria for both supportive housing and supported employment. And we also wanted to kind of give you an update on some community engagement and education and training efforts that have been underway in anticipation of an approved waiver. Again, as Nathan mentioned earlier, CMS has provided expressed support and positive responses in regards to the programmatic approach of 3. So we're doing what we can in the meantime to ensure that once approved, we can move quickly and effectively towards implementing these targeted benefits. So first of all, I wanted to take this opportunity to address some confusion we've heard regarding funds flow for Initiative 3. This is a high-level graphic you see on the slide to kind of outline where those eligible for supportive housing and supported employment benefits under the waiver will access their services. It will be simultaneously provided through 3 systems, those receiving long-term services and supports through the Aging and Long-Term Supports Administration, and are in need of the Initiative 3 benefits will access it through that system, through avenues such as the area agencies on aging and healthcare services and structures within ALTA. Those in non-integrated regions, the benefit will be provided both through managed care organizations and behavioral health organizations based on those with behavioral health conditions will access it through VHOs, and those with physical or mild to moderate behavioral health conditions will maintain access of the benefits through managed care organizations. So the service fundings will flow through these structures, and the beneficiaries will access the services just like any other Medicaid benefit through the appropriate systems. So quick overview of sort of where we are today. We are refining some key policy design elements in anticipation of an improved waiver. With support from our two work groups, the Chronic Homeless Policy Academy and the Olmsted Policy Academy, we are looking through policy items like outcome measures and indicators, quality and fidelity, the administration benefits, some issues in developing contracts with providers and through delivery systems, and identifying referral mechanisms so we ensure that those most in need of these targeted benefits have appropriate access and awareness of the targeted benefits. These elements won't be finalized until we have after a waiver approval, but this groundwork will be necessary again in order to implement the benefits as soon as possible. So a specific example, and something I alluded to previously, of these key design elements is a proposed phasing of the supportive housing benefit. A few key reasons why we are looking into phasing this benefit is because we need to ensure that this new service is matched with appropriate access to housing stock. We acknowledge that supportive housing services are only successful if they result in a stably housed individual afterwards, and we know that the benefit itself cannot pay for this this housing. So we want to make sure we can phase in this benefit to allow communities to match the services with the appropriate housing stock. We also want to take this opportunity, because it is a new benefit, to allow our delivery system partners to build the capacity necessary to provide this benefit. This isn't a new service for a lot of our providers, but providing it through Medicaid is new, and we want to make sure that the communities have the opportunity to build the capacity necessary to provide the benefit. And finally, we really do want to make sure we assess the demand for supportive housing services. Again, this is a demonstration. This is a targeted benefit, and we want to make sure that we are demonstrating the value and the impact that supportive housing can have on Medicaid beneficiaries. But by phasing this, we are able to get a better idea of just the need in our communities, and allow to, again, build that case at the end of the demonstration for the long-term sustainability for the benefits. So our proposed phasing model is to start out with the chronically homeless population, and start it out as a behavioral health organization only benefit in non-integrated regions, and then an MCO benefit in early adopter and in anticipation of mid-adopter regions as well. It would then transition to a full VHO and MCO benefit across the state for the chronic homeless population. Further population phasing, including the frequent and lengthy institutional contacts, frequent and lengthy adult residential care stays, and those with an elevated PRISM score, will be implemented as full VHO and MCO benefits without that sort of sub-phasing. But we want to make sure at the onset we take advantage of existing capacity within the behavioral health system. Certain pilots have within regions have established some pre-existing capacity and relationships for supportive housing services. So we want to take advantage of that, and we want to be able to demonstrate the benefit being provided via MCOs in fully integrated regions. And just as a quick refresh, while we do not anticipate this phasing approach would apply to the supported employment targeted benefit, but did want to make sure that we touch on the target populations for supported employment. And those include participants in the ABD or HIN programs, age, blind, and disabled, or housing and essential needs. Individuals with severe and persistent mental illness, individuals with multiple episodes of inpatient substance use treatment, and those with co-occurring conditions. In addition, working age youth, those 16 and above with behavioral health conditions are a targeted population. And also individuals eligible for long-term care services who have a traumatic brain injury. One thing I did want to also highlight that I neglected to mention is that the phasing approach for supportive housing is applicable only to the managed care organizations and behavioral health organization systems. Those receiving the benefit through ALTA, through long-term services and supports, will not be subject to this phasing approach. We did this intentionally because in order to build the capacity within the behavioral health and physical and primary care systems. So just want to make sure that was made clear. So another specific policy element, specifically in regards to the managed care the benefit being provided through managed care organizations, is medical necessity criteria. Unlike similar services that are currently available outside of Medicaid, in order for this to be a Medicaid benefit, individuals must exhibit a medical need in addition to falling under one of the previously mentioned target populations, in order to be eligible for both supportive housing and supported employment under Initiative 3 of the waiver. So there are, through behavioral health and long-term service and supports systems, they have pre-existing criteria for access to services that will continue to be in place for these targeted benefits, and those include access to care standards through behavioral health organizations, and through long-term, the ALTA's system will continue to use the comprehensive assessment and reporting evaluation or care tool to establish medical and functional need for these services. But for managed care organizations, since this is a new benefit, we wanted to provide some additional medical necessity criteria that provide some guidance for the already existing medical necessity definition found under the state plan and under WAC. And specifically, these outline functional criteria that include inability to live in an independent or family setting without support, those who are at risk or serious harm to self or others, those with dysfunction in role performance, and those at risk of further deterioration in their condition. These were actually based on functional criteria found in existing access to care standards for the behavioral health system. We are using these to apply, we intend to use these to apply to populations served under managed care organizations, as which is intentional in order to provide a level of consistency across systems as these benefits are implemented through the waiver. So as I mentioned before, that we are trying to lay as much groundwork as possible in anticipation of an approved waiver. We know there's a lot of interest in how providers, delivery systems, and other stakeholders can prepare for the targeted benefits in Initiative 3. So we were trying to take advantage of existing technical assistance resources, existing conferences, and existing pilots in order to educate and train providers and other interested parties on on what the benefits are, how we intend to implement them, and what steps the community members need to take in order to be prepared to provide the benefits under an approved waiver. Our partners at the Division of Behavioral Health and Recovery, DBHR, offer monthly webinars and technical assistance supports for both supportive housing and supported employment. This assistance is also available to managed care organizations and accountable communities of health. We are participating in several upcoming conferences, facilitating trainings and workshops, specifically the upcoming conference to end homelessness in Spokane in May, the Washington Behavioral Health Care Conference in June, Supported Employment Conference in August, and the Co-occurring Disorder Conference in October. We intend to provide as much information as we can in anticipation of implementing the benefit so that our community partners can have all the information and preparation they need in order to participate and provide these targeted services. We also have DBHR is also managing several pilot projects that provide both supportive housing and supported employment benefits in specific regions throughout the state. More information can be found on fact sheets available on the DBHR website, so we encourage you to look at those more closely to kind of find out more information about how we are providing similar services through our behavioral health system now. So that those, so please do access the websites for those resources. With that, I want to transition to Nathan so we can start addressing some questions across the webinar. Thank you.
Thanks, John. And we recognize this first hour has been a lot of us talking at you or to you, and now we want to engage with you at least through questions that have already been submitted. So many of you have already provided a great set of questions to get started on, and I want to encourage folks who haven't yet typed them in, and we will obviously get to as many of these as possible over the next hour. If we need the full hour, we will use it. In addition, before we go into the Q&A, and I'll provide these details at the end of the webinar as well, because of very unanticipated technical issues with regard to the participation of more than a certain number of folks, a lot of folks who've tried to participate in the webinar have been unable to. So what we're planning to do is to actually do webinar 2.0, another live webinar later this afternoon at 3:30. We'll be sending a link out at the conclusion of this webinar with registration. So if folks want to sit through another hour and a half with this team, they are welcome to do so, or to engage us in what I anticipate will be a briefer presentation and more Q&A. In addition, this webinar itself will be posted as immediately as possible at the conclusion of this next hour. So for folks who have colleagues who have been unable to join us thus far, please let them know if you'd like that there will be another opportunity later this afternoon, as well as, again, a posting of this recording shortly. So I'm going to start in no particular order here, but with a question that came in that I'm going to actually direct to Kaylee, if she's all right with that. And the question is, will the current framework be included, or will the responses to the survey be integrated?
Thanks. So the survey that is going to be available later today has several very direct questions that will help us move forward as we continue to develop the eventual project toolkit. I think with the questions that are in the survey, you'll see that we're just trying to get more information from our stakeholders and partners in understanding from a regional and community perspective how the different projects listed in the framework can really work together and reinforce one another. So this won't be to provide guidance on a edited or revised project framework. It's really to help us move forward in the next phase of this process.
Thanks, Kaylee, and I suspect others may have questions about the framework document itself, and we'll encourage those to keep coming. The next question is a question related to one of the earlier slides we went over under Initiative 1, and that's a question of how the quality and challenge pools would be financed. Again, what I want to assure folks is more supporting information and details in coming weeks. We did, again, want to present a high-level case today. Suffice to say for this purpose that we envision those quality and challenge pools initially being financed through waiver investment means, and that's particularly federal investment under Initiative 1. We'll have more to say on that and more details to share with you, but that is, in fact, how we envision them being financed, at least initially. Another question that's come in, and these are fantastic questions, folks, so keep them coming. The question is, are the metrics from the waiver projects limited to the common measure set? Are these metrics also used to set incentive payments? One thing you heard me say and others say throughout the presentation is the import of aligning the metrics across multiple platforms. That is our commitment. As part of that commitment, we do intend to leverage the common measure set to the greatest possible degree. In addition, we would intend that for projects that are being evaluated against those metrics, that the financial incentives themselves are very aligned to those metrics. Understand that this waiver will be a bit of a learning process and a learning endeavor, in that initially those metrics that are being used to justify incentive payments will be more process-oriented, and outcome metrics we envision being utilized in years 3 through year 5 of the waiver. At least that's how we approached it in the waiver application. The next question is, and I'm going to direct this to Kaylee, will the current Initiative 1 framework be submitted to CMS, or will responses to the survey be integrated before submission? And tied to that, what is the timeline in the process for drafting the project toolkit for CMS approval? If you'd be willing to cover both of those.
Sure. So it is our intent to share the framework that is on the website with CMS as part of ongoing discussions. It's not necessarily a formal submission to them. It will just be part of conversations. So that said, as survey responses come in or other comments through email, we will, of course, consider all of that as we continue in conversations with CMS. Regarding the timeline and process for drafting the project toolkit, we expect that this is going to take several weeks, perhaps months. It really depends on how the negotiations with CMS continue. The final toolkit is something that we anticipate to be a deliverable after finalized special terms and conditions with CMS. This is typically in other states' demonstrations something that is a deliverable back to CMS within 60 days after a final signing of special terms and conditions. So that's not exactly the perfect answer to a timeline question, but just understand that it's part of the process and that we will continue working on this in the coming weeks. And of course, we'll share more information as we have it.
Okay, and one more question related to projects that I'll try to take, and then I think we have some specific questions on Initiative 2 and 3 that I want to prepare B and John for to take next. The question is, can the ACHs participate in the selection of the project metrics with the state? And what I would assure folks is, as we're establishing metrics, again, consistent as much as possible with the common measure set, with our contractual approaches and the measures that folks are already growing accustomed to, that at least consistent with that alignment approach that we're taking, we absolutely intend to consult accountable communities of health and the member organizations that constitute those accountable communities of health to make sure that we're aiming the right direction. So there will be more to come on that front, especially with the further development of the project toolkit, but want to assure folks that there will be plenty of consultation on this point going forward. So next I want to pivot, if I might, to the Initiative 3 questions, and I'm actually going to have John, you read the questions because you might have some insight into this.
Sure. Sure. Thanks, Nathan. So first I do want to take a quick question about the phase-in approach for supportive housing, and specifically when you say it is the supportive housing benefit will be phased in only by DHOs and MCOs, will there be providers that are providing Medicaid eligible services that will not be able to initially provide services to certain populations? And so the phase-in would mean that even if you were, as a provider, were receiving Medicaid reimbursable services, if you're providing those services that for supportive housing beneficiaries, initially it would be limited just to the chronic homeless population, and then it would be expanded from there. So yes, if you had individuals who fell into the frequent use of institutional, frequent or lengthy use of institutions, or adult residential care stays, and we're still early in that phase-in process, those individuals would not yet be eligible for Medicaid services. So but we are still working out a lot of the details about how exactly this will work in implementation and what, how long, what the timeline is for phasing. But that the order and sort of that process is what we are looking to move forward with now. But that does mean that at least initially there will be certain target populations who will not yet be eligible until later on in the phasing process. One question I do want to clarify, explain more about why the supportive housing component excludes ALTA's Medicaid beneficiaries. I just want to be clear, it does not. This is only the phasing process that is separate from ALTA's, that separates ALTA. Beneficiaries accessing long-term services and supports under ALTA's system will be able to access supportive housing benefits from the get-go. They will not be part of that population phasing as discussed for MCOs and BHOs. So they are not excluded from the benefit, only from the phasing process. Will the supportive housing and supportive employment benefits be available to MCOs in non-integrated regions as well as the BHOs or just the BHOs? So again, initially for the chronic homeless population, it will initially be a BHO only benefit in non-integrated regions. In integrated regions will be accessed via MCOs. As we phase it in, it will be available via both BHOs and MCOs. And follow-up question is, what are the expectations around coordination between BHOs and MCOs around who takes responsibility? A lot of these details will continue to be worked out as we move towards implementation, but at the same time, we do expect that the lines that currently exist between beneficiaries who access Medicaid services through MCOs and those who access them through BHOs will remain consistent for supportive housing. So those with behavioral health conditions will access it through BHOs, and those with physical or mild to moderate will access them through MCOs. Quick question on the more information on the Supported Employment Conference in August. Right now we're in the initial planning stages of it, so more information will be posted on the DBHR website, and we'll make sure that that gets posted on the Initiative 3 website for the waiver as well.
Great, John. Thank you. That was we're getting a lot of really good questions on all the initiatives, and thank you for covering those on Initiative 3. Right now, B, I'm looking for any on Initiative 2, and I'm not sure that we have received any yet, but we'll keep you appraised, and we'll get you to address those in a moment if they come in.
Okay, thank you.
Great. One of the questions that's come in, I think, related to the framework, and that is a question of whether chronic disease projects will be limited to just those conditions included in the common measure set. We have not made that decision, and we would invite further comments on whether that is appropriate or not. I think the common measure set did help identify some significant priorities that all payers, including the Medicaid program, are dealing with. But I wouldn't want to rule anything out at this stage, nor have we done that for purposes of developing the Project Toolkit. So to this questioner and to others interested in this topic, we would invite further comments, in particular through the survey instrument related to the project framework. Another question related to the development of the Project Toolkit and whether that will be, I think the frame was to whether it will be co-created with ACHs and other stakeholders. What we do envision is a vetting process for each phase of the development of the toolkit. So just as we are collecting your feedback on the project framework through a survey instrument, we do envision further public participation in the development of the toolkit through a variety of means. And what I would also comment in response to this question is we have received, months ago now, we have received from many of you an amazing array of project ideas. Over 180 of them were submitted, many with overlapping elements that are now reflected very much so in the framework document itself. And we will be continuing to leverage those project idea submittals through each phase of the toolkit process, and in many ways the content that has already been supplied to us is in fact the ingredient list for development of the toolkit. So I want to impress that upon folks as well. That work will continue to serve as a strong foundation for toolkit development. I think we have a few other questions related to project opportunities in the framework document, and again, I'll just say great real substantive questions here. The next is, how will potential statewide project opportunities be accommodated by the waiver project menu and process? For instance, would all ACHs need to submit the same project for it to have statewide application? I think what the framework begins to describe is that there will be activities occurring on a statewide basis, even with some regional dimensions associated, whether in the frame of value-based payment, care coordination, or integrated care. I think we've always described in previous discussions the notion that integrated care and value-based payment are statewide projects, statewide approaches that we envision carrying out under the waiver. And I think the framework furthers this discussion, and we would invite your further feedback in the responses. We also want to recognize, though, that the approach to integrated care, the approach to value-based payment, the approach to care coordination at times needs to be different by geography, by population being served and such, and we are trying to manage that needed value-add variation into this process as well. And we recognize there is a tension there of having statewide sustainable transformation, but as well regionally appropriate, culturally competent transformation activities moving forward. And again, I won't suggest we have that all figured out today. I think the framework takes us further steps, though, that direction of balancing statewideness and regional differentiation. And if it doesn't do that, we invite your further comments and questions. Another question related to the framework, and I think it picks up on how we've discussed this previously, so I do want to come back to this. Will a project that proposes to pilot an innovation to transform an existing program or model that currently receives Medicaid funding be eligible for waiver funding if the waiver funding would only support the new cost of piloting the innovation and not replace any Medicaid funds? While I don't think we have a hard and fast response to this today, I think we have discussed and hopefully been consistent in previous forums like webinars that the scale and spread of existing evidence-based models is absolutely an appropriate waiver investment. In fact, CMS and the Healthcare Authority and DSHS all have a strong bias towards leveraging evidence-based models, some of which are already in practice in the state. But the notable component of this question, and something I would stress, is I think we will all need to be very careful to justify those investments and ensuring that they are not supplanting existing Medicaid or other grant investments. This is about furthering the scale and spread of models that we know work on a regional and statewide basis, and I think that's the opportunity the waiver affords us. Hopefully that's clear, and hopefully we've been consistent on that. Kaylee might have something to add.
Yeah, I would just add to keep in mind, back to that slide about how incentive payments flow is very different than how dollars are flowing now for certain programs or services. This is not providing a service and you'll just put in a claim and be reimbursed. It's on a, whether it be quarterly basis or something different that still has yet to be determined, but it is based on achieving certain milestones will allow the dollars to flow. So I think it's just important when thinking about how, what types of investments we're making and how those dollars actually flow really has to be something that we consider in how we structure these activities.
And Kaylee, I'm going to throw one right back in your court on project timeline and speaking to what is still an aggressive timeline for Project Toolkit development and the anticipated start date of a waiver, which is rolling itself. And the question is, how will ACHs be able to pursue additional projects or adaptations to projects beyond an official start date, if it is, in fact, January 1, 2017 for starting Initiative 1 projects, or a later date? Is it on a rolling basis as learning happens, or are there aligned opportunities that might come together well after January 1st and how we're envisioning it?
Great. So some of the very first activities that will occur after an approved waiver is having ACHs in there with their partners developing a plan for undertaking those transformation activities. Part of that plan is to figure out, using the Project Toolkit, what's the activities are that region is undertaking and how. And part of that plan will really determine how the project implementation is to begin. We use sometimes the terminology soft launch because it won't just be, on any given day, whether it's January 1, 2017 or another date, that everything just seems to align perfectly and everything's ready to go. There will be some activities that are going to have to start and then others phase in, and a lot of that will really depend on the region itself and where the baseline starting point is.
Great. Another question, and I'm going to throw this back your way, Kaylee. I've been busy today. Are there waiver dollars that can be used to help with developing the ACH infrastructure to handle the implementation efforts under the waiver?
It is our expectation that we will be able to negotiate with CMS for significant planning dollars and resources to support the ACHs and the provider organizations in preparing to undertake these transformation activities. So yes, there will be support both financially and in terms of technical assistance to during a ramp-up phase. While we don't have a year zero, and many of you who participated in the last webinar back in February had heard us speak to that, we do expect there will be opportunity for ramping up and building that infrastructure.
Thanks, Kaylee. I'll take one off your plate now. Here's a question. Dealing with the legislative appropriation for the waiver that's in the budget that was passed and signed into law. The question is, aren't there some caps on the matching funds, the federal appropriation side? Will this slow down or impede the 1115 waiver if it is in fact approved? Good question. I think for all three initiatives, we believe across our agencies that there is sufficient federal appropriation to do the necessary implementation work in the early period following waiver approval. What we recognize in both the short and long term is those appropriation levels will absolutely, once there's more certainty around the waiver, have to be addressed for both perhaps 2017 supplemental purposes, but as well the longer term 17-19 biennial budget, which will be the focus of the next legislative. So we believe the appropriation again is sufficient for where we will need to be between now and the next session, but we also recognize absolutely that as the detailed budget elements of the waiver are agreed to, that we'll need to come back and revisit the appropriation levels as appropriate. So I hope that addresses your question. Question here, would the toolkit include criteria to select transformation projects, and would this include evidence-based activities only? I'm going to go ahead and take a portion of this question, and I'm also going to have Kaylee perhaps fill in the cracks here. The toolkit is absolutely intended to include criteria that builds, again, on the framework that has been distributed, builds on the project ideas that have been submitted to date. The question of whether it will only include room for, quote, evidence-based activities, I think definitionally we do want to rely on evidence, but there's a broader array, and it's both in statute and as a matter of practice how our agencies approach this question, and promising practices and research-based approaches that may not meet strict evidence-based criteria as we think of it in more of a statutory or regulatory sense will absolutely be a consideration. But what we want is there to be some signal, some established approach that whether it's been tried in other communities or whether there's a great deal of documentation behind it, we want there to be, we want to be focused on those efforts that are most likely to succeed. That said, there are certain subpopulations, there are certain groups of individuals for which there is not much research, evidence, or even promising practices established. We want to be incredibly mindful of that. So whether on a geographic basis or other demographic basis, our innovation is serving the entire Medicaid population adequately and appropriately through our interventions. So great question, and I hope that addresses what you were asking about. Do you want to say anything more about the criteria piece of this question, Kaylee?
Yeah, I think as we, again, work towards and share the eventual project toolkit, I think things will start to, again, just get clear in what these transformation activities look like. In addition to the project toolkit, we also expect that we'll have to provide additional guidance and templates around what we expect regions and ACHs to be putting together in terms of a transformation plan application that will really ask the questions that we need to know in terms of how those activities are being implemented and undertaken in any given region.
Great. I'm going to have John take the next question on Initiative 3.
Sure. And this has reference to Initiative 2 as well, B, so I'll let you jump in if you'd like. But the question is, can you share where appropriate affordable access to timely transportation fits within Initiative 2 and 3 frameworks? While at least for Initiative 3, these services under supportive housing and supported employment are very specific. We're following very specific CMS guidance on what can be included in these benefits, and actual transportation does not directly fall under these. The part of the service coordination and support and resource navigation is very much part of Initiative 3 benefits for both supportive housing and supported employment. So it would be on those case managers or case coordinators to ensure that beneficiaries, those enrolled in those benefits, are aware of and have access to other supports that would allow for timely and affordable transportation. B, did you have anything to add for Initiative 2 on that?
I would say transportation is not something currently covered under family caregiver support services, so it's not something that we have envisioned in MAC. There may be an opportunity for limited transportation within TSOA, but my guess is it's not going to fully meet the unmet needs that are out there for transportation.
Great, thanks. I'll just take one more question regarding Initiative 3. Is the state considering using the Health Benefit Exchange certified health plan finder navigators and brokers for taking applications for supportive housing and supportive employment services? So a quick clarification, it wouldn't be an application for services like an application to or enrollment in Medicaid service as a whole. It really being enrolled in Medicaid is the first hurdle for individuals in accessing Initiative 3 benefits. And so while navigators and brokers certainly could help refer potentially eligible beneficiaries to providers, and we will certainly hope to provide information and engagement to all relevant parties who would be involved in connecting individuals with these benefits. The direct application wouldn't be part of that role. The eligibility and enrollment in services will really fall on the providers, those licensed and certified to provide these services, and so that's where the sort of eligibility and enrollment in services will occur.
Thanks, John. I'm going to line up two questions on Toolkit. Some of this we've covered already, but because the two questions are coming in like this, I think it'd be worth talking about in further detail. I'm going to have Kaylee first respond to these and others weigh in as appropriate. So here they are. Can you be more specific about the relationship of the transformation concepts and the toolkit? Specifically, will the toolkit be the mechanism for deciding what concepts will move forward toward a project design for funding? And on a related question, could projects that address the common measures set metrics but aren't currently listed under objectives and outcomes be considered as the toolkit gets developed? So related questions for you.
So first, yes, the framework, and which will then fuel the eventual project toolkit, are mapping out and outlining the investment areas for Medicaid transformation. We believe that these themes are very reflective of how this work first began, beginning with the concept paper a year ago now, last May, as well as from the waiver application and from the many project ideas that we received. So when you review the framework, you'll see there's still a lot of flexibility in those project investment areas, though we do expect that those major projects listed in domains 1, 2, and 3 will be the investment areas through the Medicaid transformation waiver. You'll have to remind me of the other parts of the question.
Well, I just passed them over. So I think the other part, I think you actually addressed those questions because they were very tied together. Sorry. And if folks don't think we did, they have ability to weigh in. So let us know how we did on that, and keep letting us know if further clarification on any of these is needed. I want to deal with two finance-related questions that are separate, so I'll deal with them separately. The first is, can you talk more about the financial management function of the ACHs with regard to the waiver? Is the state selecting a vendor, or will there be a selected vendor list for the ACHs to choose from? No absolute decisions on this front, but lots of discussion that has taken place with a representative group of accountable communities of health helping inform our thinking on this. And I think the message we have heard pretty loud and clear from ACHs is some desire to have more structure and, shall we say, a framework that they wouldn't necessarily be directly responsible for the handling of funds and payment of funds under the incentive program of Initiative 1. So what we're contemplating is an approach where the state would be selecting a vendor or vendors to carry out that function as more of an executor role. So not the decision-making function per se, not the ultimate performance accountability. That's not what's being envisioned to be contracted out. But what has changed from prior conversations where we have often called out various back office and financial management functions that could be or should be contracted out, what has changed in some of our thinking, again, largely informed by ACHs and members of ACHs as well as others, is taking a more directive approach on how finances would be managed and handled. And again, we have not absolutely landed on any particular decision with regard to whether that will be a single statewide vendor or a list of multiple vendors. We would invite your feedback from any of you who might be interested in that question. I think there are pros and cons probably to these approaches, and we are working, mind you, on a document, a public-facing document that will, I think, help further this discussion around financial management and put some criteria out for further discussions on this. But to be clear, we have not landed on an absolute decision, but are certainly contemplating the state's role in selecting vendors or a vendor for this responsibility. Unrelated, but I think relevant to the financing discussion overall, should or could counties or regions identify sources of funding that could serve as the base for IGT? What programs are included in DSHP are the two components of that question. Starting with the first, we have identified, largely because it has been the makeup of previous Medicaid demonstrations in other states, we have identified public hospitals as the most likely entities for IGT match. In those other Medicaid demonstrations, at least that we have to look to as examples here, county governments, although eligible technically to be sources of IGT, have not been leaned on, at least not leaned on very heavily. So whether county governmental entities or other non-hospital governmental entities be sources of IGT, technically yes. I think we would have to think through further the programmatic implications and getting balance across the state. That's one very key component here is you want a balance of resources to be distributed across the state. And so we would invite further dialogue on that, but for now are fairly set on an approach that would engage public hospitals directly in this question. Again, based on precedent both in this state and in other Medicaid demonstrations. The further question is what programs are included in the designated state health program list. I think we're getting far enough and close enough in CMS discussions that we will be providing such a list for public review fairly soon. I don't know how soon. I don't want to pledge a date here so that everyone can have a full sense for what programs we think are eligible. What I should clarify, though, about the DSHP programs is there is no change to those programs or their underlying funding on account of them being considered as a designated state health program. But what it does allow us to do by sourcing these programs and explaining the programmatic expenditures to CMS is it allows us to draw in that federal match that can be used for Medicaid transformation investment. So I would pledge to share more details on this as soon as we feel like they're ready to share and actually legitimate, approvable, as we think of it from a federal level, DSHPs, designated state health programs. So we'll pledge to you that that information will be coming shortly. And keep your questions coming in as well as any clarifying questions based on the responses of this group. there is a question here, and I'm going to try to interpret it, and so I would invite the questioner, if I don't interpret it correctly, to correct me. The question is whether ACHs who've already entered into a transformation project, whether the pursuit of transformation projects under the waiver represent any type of conflict potentially. I think I'm getting that right in terms of the intent of the question. And what we do recognize is ACHs, even in many cases, regional collaboratives prior to them being designated as ACHs, have been engaged in transformative projects across their regions for a long period of time. And the waiver is not about undermining those activities or supplanting them, but complementing them and adding to their scale and spread. So we actually don't perceive a conflict here. There are deliverables that are specific to the State Innovation Model Grant, and we will be clear, I think, as we go forward, that waiver investments and funding associated with additional projects for Medicaid purposes will need to be distinct and separate from other grant-funded or otherwise funded activities. This would also be an important point to note that all accountable communities of health have a responsibility to themselves, to each other, and to populations that extend far beyond the Medicaid population. ACHs are constituted to achieve triple aim objectives for the whole population within their regions. And so while Medicaid is a great tool and the waiver is a great tool, we recognize that there will be many projects, we're assuming anyway, at an ACH level that may not be leveraging Medicaid waiver funding now or in the future, and something I think important to keep in consideration. So if I mangled that question, let me know, and I'll try to be as responsive as possible. A question to clarify some earlier comments on IGT, and the question is, by public hospitals, do we mean public district hospitals or nonprofit hospitals? Very good clarification question. Thank you for asking. The federal statute doesn't define much around waivers or around non-federal share sources, but they do define, at least in one sentence or two, what is an appropriate source for intergovernmental transfer. And it does need to be a public entity, which we would mean government-controlled or operated facility that has a public source of funding behind it. So this does not expand or include nonprofit hospitals that are separately governed in a corporate structure outside of government, but would include public hospital districts and other government-operated or government-run or government-funded facilities. I hope that is a clarification for folks. Public entity is a defined term in federal statute, and we're trying to be mindful of that. I'm checking to see if there's any other questions coming in. I hope we're addressing the interest level and questions that do exist. One of the questions is around whether the state is building the capacity to measure baseline hospital performance, especially with the changeover from ICD-9 to ICD-10. And I would suggest to you that I think we're all in the middle of ensuring that all of our metrics and the way we approach measurement align to the new ICD-10 standards. And while I can't give you specifics on our adaptation in that direction, I will say the entire measurement architecture that's being funded, both as it's envisioned under the waiver, but even prior to that through State Innovation Model Grant investments, is trying to take into account how that data is being collected, recognizing we are still, to a degree, in a transition period, and recognizing that some of those national metrics that we are leaning on don't yet have an ICD-10 scoped out approach to that metric, if you can believe it. So we're working on it. This is a very active discussion and issue, and we're going to be as responsive as possible to the federal and national data environment and standards that are in use. And then I think one question, and I'm going to try to reinterpret the question to what I think it is, and again, someone can correct us if we get this wrong, and I'm going to direct this to Kaylee, and it's how will that final Project Toolkit process relate to the ACHs being ready to take on this task, and the timelines that are parallel but are different in terms of the Project Toolkit being prepared and ACHs themselves being prepared to take on the task. Do you want to hit on that a little bit?
Sure. So the Project Toolkit is one deliverable, one large activity. Parallel to that will be additional eventual guidance around how ACHs can demonstrate readiness to fulfill a role in Medicaid transformation and additional guidance on how to and what a transformation project plan application would look like. So there's several activities that will have to happen and that we will eventually owe to CMS for their approval for the Medicaid waiver. So the Project Toolkit being one, which will obviously influence ACH readiness as well as the transformation project plan application. So hopefully that answers the question. I know it's a little bit confusing because there's a lot of things that we don't have yet, but we expect will all be key deliverables within the very beginning months after approval from CMS.
Great. Here's a question. Thank you for this. Any other details that you can share about the community reinvestment pool, timing, for instance, and how this might impact ACHs? And I think you're referencing back to the slide on value-based payment. Again, we recognize we had to rush through that discussion a little bit today to get to all the content on the webinar, and we will be in the very near term releasing further kind of background materials that further explain in writing the visual that you saw today. We would see the timing of this coinciding with the launch of the waiver itself and the launch of Initiative 1. We think it's an important concept to get right. But in terms of the reinvestment component, certainly that needs to be stipulated up front, but what dollars would be available for reinvestment might be something more accessible, more available by year 2 or year 3 of the demonstration period. We'll give you more details on that, but what we're envisioning for the reinvestment pool and the challenge pool is that unearned incentives, so that is dollars that are not achieved by virtue of the incentive structure in year 1, would be available as reinvestment or challenge rewards in year 2 or year 3, for example. I hope that provides some further detail for you, and in the fairly near term we'll be providing something I think even more helpful that dips into a deeper level of detail on this for you. We would see that ACHs would be the entity through their membership taking advantage of the reinvestment pool, and again I think we suggested the challenge pool would be available to award exceptional managed care health system performance. I hope that clarifies. We're going to do a pause here. We do have some more time, and I want to make sure that we've gotten to as many of your questions as possible here. But would note that we've already been into this for an hour and 40 minutes with you all, so I suggest we might be getting to lunchtime too. So I'm going to pause here for just a few seconds and make sure nothing in addition comes in from you all. And I'll take this pause to not really pause, but also remind folks that we are going to take another shot at this at 3:30 through a live webinar. It'll be a slightly different format, although covering the same content. We'll provide even more time on that webinar for Q&A. It's possible that some of you on this version of the webinar, 1.0, will have further thoughts and reflections by version 2.0, and we would invite you to that further discussion, although again we will be reviewing some of the same content from this version. Again, we regret that, but it was an issue we were not aware of until this webinar had launched, so we apologize for the inconvenience it may have caused to any of your colleagues that are not on with us at this moment. I'm also looking around the room for any additional reflections from our team members. We have folks from DSHS here in the room and on the phone. Marianne, Mark, Kaylee, anything to add based on the discussion today? Or John?
I just want to express appreciation for all the participation and the great questions, so thank you.
Yeah, we do hope, and we hope future webinars will be the same, but we hope today was informative and substantive. And we hope we balanced further detail with plenty of room for questions and answers on that detail. And of course, we pledge continued engagement with you all on some of these very significant issues, both through virtual means as well as through additional webinars going forward. Would also stress the comments both Kaylee and Marianne shared with regard to the survey response vehicle, and this is the best way, in addition to questions you posed to us today, but the best way of gauging your response and your insight into that framework, and will absolutely be used to inform further development of the toolkit. So if anyone has any challenges accessing it or any questions about completing that survey response, would you please let us know, and we'll make sure to be attentive to that. I'm checking with the team to make sure we have one more. Okay, good. We'll make sure to get to that before we hang up the line here.
Actually, as that question coming in, this is Mark, just another reminder that we will be getting a survey out and would encourage you to take advantage of that survey to send us additional feedback, which we very much appreciate.
So this last question that came in, can you share more information about a potential certification process for ACHs relative to the waiver? So I'll go ahead and speak to that. It is our expectation that there will have to be some method of gauging ACH readiness to fulfill the role in Medicaid transformation, and that's what we refer to as this certification process. Other than an acknowledgement that we know this is something that we'll have to consider further and expect that CMS will also be interested in that as well. It's a key milestone for sometime after an approved waiver and final special terms and conditions, and we've have some initial guidelines around what that certification might include, that we had received some recommendations from an outside consultant, but there's still a lot more work around that to come, and we'll be working with our ACH partners on that front as well.
We have another question that's just come in. So keep them coming. We have time, and we are committed to spending as much time as possible to address these questions. And a portion of this you might want to address, Kaylee, as well. How do community-based organizations engage in the waiver projects? Is it through contracts with delivery system providers, or do they need to become eligible for Medicaid reimbursement? A fantastic question, and I think a clear and key differentiator of Washington's approach to the approaches taken in other states. So I think it would be important to spend some time on this, and thank you for this question. First, we envision the broad engagement of community partners that is already occurring to varying degrees through accountable communities of health, being further supported through the waiver and through the central role the accountable community of health will have in organizing project applications. We do not envision, nor would we want to as a matter of sustainability, creating the need for community organizations and others to become, quote, Medicaid providers in a traditional sense. While there will absolutely be, as elements of the project application will require written agreements, understandings, contracts that associate any of the incentive payments with those organizations receiving them. Again, we do not envision this needing to take place by those folks becoming a traditional provider itself. The further question is whether it's through contracts with delivery systems or some other vehicle that they will be eligible. It says for Medicaid reimbursement, but I anticipate the question is really around the projects under Initiative 1. And that eligibility will be something addressed in the project application. And honestly, eligibility for incentive payments is an issue of finer detail that also still needs to be addressed through the terms and conditions process with CMS. In other states, most in my mind is New York. They've stipulated a kind of a threshold test or a percentage of investment dollars that could go to non-traditional providers, community organizations. We have been very careful not to suggest a proportional test of that kind, but we are at this stage not entirely sure where CMS and their own authorizing environment might take the conversation. But in summary, and I think again to a very important question, we are envisioning the very significant role of community partners outside of traditional providers being facilitated through accountable communities of health and further established through the project application process. I hope that's clarifying.
So another question, how many waiver projects do you estimate each region will be implementing? So if you look at the framework that's available on our website, within the 3 domains, I think there's 8 total project themes. Within domains 2 and 3, there's 5 major themes: bidirectional integration of care, care coordination, care transitions, chronic disease management, and maternal and child health. Domain 1 has some project themes as well, However, Domain 1 really needs to reinforce the activities in Domains 2 and 3. So in that, it's treated a little bit differently and really will depend on how the region is undertaking those projects within Domains 2 and 3. One of the questions that we have put forth in the survey that we'll be releasing gets at this question of whether the 5 projects listed within Domain 2 and 3 make sense as a mandatory project undertaking within each of the ACH regions. So if, let's say they were, that would be 5 projects within Domain 2 and 3 that each region would be implementing in addition to those in Domain 1 that help reinforce those. So it's still not a final decision on that and would encourage feedback on that question, but the framework I think starts to get at demonstrating that we're not looking at a project toolkit of 40 different projects. We really are thinking about this a little bit narrower, but focusing on those projects that are going to help support the system's change.
Great. Well, we have 2 questions that have come in incidentally from separate folks, but are related, and so I'm going to try to address them in a related fashion and invite my colleagues to also weigh in, just with some of the limited time we have left here. So I'll read the questions in a series here. As many ACH backbones also provide services, will organizations that serve as backbones be eligible to apply to provide projects or to oversee projects, I think? The second question is, if financial management would potentially be managed by the state via contracted entity, would ACHs still need to become legal entities or address their legal structure? These actually are related questions, so let me try to tie these 2 threads together. We do recognize that there is a long and proud tradition of regional organizations at times providing direct services. In no way would we want to get in the way of that. But crucially, the model under the Medicaid transformation waiver is not for ACHs to be the service entity, but rather the convener and decision-making entity around projects and a vehicle for sustaining them. This is what actually makes important this role that an ACH has from a governance and decision-making standpoint, as it is distinct from the role of a backbone organization that may in fact have a service delivery model or component underneath it. And we have talked with some of you, in particular in the ACH realm, about this before, but one of the reasons we do think that each ACH will need to come up with a regionally appropriate and stakeholder-specific response to some understanding of legal entity status is to address this issue to ensure that that any potential conflicts between a backbone service delivery model and the decision-making of an ACH body, that those conflicts could be managed appropriately with appropriate accountability distilled between those 2. There's certainly more to come on this, and we invite further feedback on how to balance this. But again, I think bottom line, 2 main points. 1, we do not intend to undermine any of the very reputable organizations that are doing some of this great and critical work. Number 2, we think the role for an ACH in its decision-making and governance around Initiative 1 is very crucial and needs to have a structure underneath it that supports that role. So thank you for the questions, both of them, on that subject. Great question, and this is a great one probably to wrap it up on if we have some limited time here. So the question is this: what further thinking have you all done regarding a mechanism for savings reinvestment? What I would suggest is we've done a great deal of thinking and are providing kind of the first overview document that reflects that thinking around value-based payment. Getting the Medicaid business model, especially around reimbursement, aligned to the incentives and transformation objectives we're pursuing is incredibly critical. And as a sustainability vehicle as well as a vehicle for reinvestment, we think the approach to managed care contracting will play a considerable role, not the exclusive role, but a considerable role given all the dollars that managed care health systems are responsible for, and as they increasingly need to hit themselves value-based payment targets, those very much have a reinvestment component in them, and in the way many of those VBP arrangements today are already structured, separate and apart from this waiver process. What I suspect this question is dipping into is the broader discussion around reinvestment, maybe above and beyond what is occurring simply in Medicaid risk-bearing entities or managed healthcare systems as we know them today. And that is still in development. One of the things we are seeking to support through separately funded means under the State Innovation Model Grant is some statewide technical assistance and facilitated discussion on this topic. What we've heard loud and clear from accountable communities of health in particular and their members is that reinvestment is a deep enough and a sticky enough issue and an important enough issue to get right that just having region-level discussions around this is not cutting it. So we do intend, through State Innovation Model Grant resources, independent of the waiver, to provide some assistance and facilitated discussion on this topic. But there has been further thinking. A lot of it's reflected in our value-based payment approach. We also recognize the reinvestment discussion should extend beyond that. And while I'm on the point, I should also make sure to mention that speaking of reinvestment and innovative approaches to reinvestment, we do have a request for information that is out in the field now on the Pay for Success model, which is looking at a complementary investment approach to that of the waiver and of the SIM grant, and a potential sustainability mechanism that brings other funders to the table for very relevant and critical services. And we hope those of you who have an interest in this issue are taking a good look at that RFI and considering a response. I don't recall the deadline of that response.
May 6th will be the deadline for responses.
May 6th is the response. So there has been work. There's going to be further work ahead of us. And these are major league issues that, let's be honest, there's no template for. No one has figured out yet. So I think it's one of the exciting aspects of both the waiver and the broader discussion ahead of us. Unless we have any pressing or urgent questions that have come in since this, I want to bring this webinar to a wrap and really, again, thank you to all of the folks who have stuck with us for a lengthy webinar. We pledge that not all of these will be a full 2 hours, but we had a lot to update you on today. Again, I want to land and restate, we will be doing a 3:30 webinar 2.0 with the same cast and crew, also with the capability and intention of addressing your further questions that any of you on this call might have. And again, we regret some of the technical issues we had this morning. So thanks again. These questions were incredible. We felt that you were very engaged with us. Even as we're reading the questions, we felt a level of engagement. I think that was very useful to this process. So unless anyone has any other words of wisdom, okay, we'll bring this to conclusion. Thank you all again for your time today.